So I guess, thank you all for joining us. And just so you all know,
has been permitted to talk.
Great. Just so you all know, this will definitely be recorded and posted on our website. So for those who aren't able to get in or are having challenges, all of this can be reviewed at a later time, hopefully as soon as we get done. So I want to say that. And then also I just want to thank everyone for this this has been such a challenging time. And as an acupuncture community, there's been lots of questions and confusion, and but we've also really done a good job of at least doing the best we can. So I'm really excited to be able to do this town hall. Thank you, Valerie. Thank you, Steve. Thank you, Lara, for agreeing to talk and kind of help us guide through what is most important for us is, one, obviously following the government regulations, but also reviewing what we already know. So our clean needle technique, our OSHA standards, and then those updates to those. And that's primarily what Valerie and Steve are gonna do to begin with. And I think Elizabeth, if there's important questions, is gonna come in and help guide us through if there's any Q&As. With that, Stacy's gonna help introduce Valerie and Steve, and we'll go from there. Thanks.
Before you do that, can we just really quick, since the assumption is that there are people on this meeting who were not in the first meeting, so we can just let Elizabeth speak for a little bit about her role as a moderator and how to send in questions.
Great.
Okay. Hi, everyone. Can you hear me? This is Elizabeth. And my name is Elizabeth Franz. I'm the mediator for today. I'm going to be moderating the questions. And please put your questions in the Q&A section. I will be keeping a record of all the questions and answers as they're typed out in that area. And that will also be sent out at the end. I am a neutral party, so I'm just going to be paying attention to questions that may be asked multiple times. And then I'm going to push those up in the queue to make sure they get asked. And because it's the platform today, we won't be able to get to every question during the call, but we will have a record of all of them. And the ones that are most urgent, point of orders, questions that we need to address in the moment, or questions that are asked multiple times, I'll prioritize and I'll verbally ask those questions on the call so we don't have too much chaos.
All right, thank you, Elizabeth.
Okay, ready for me to introduce everybody?
You betcha.
Hi, I'm Dr. Stacy Donaldson, and I run the Colorado Acupuncture Group on Facebook, where a lot of our discussions on COVID and clinic practice and opening and reopening and just trying to figure out all the chaos and make order out of it for the last few weeks has been discussions and ongoing. And I had talked to Casey about creating kind of this town hall for us to talk with people that I knew, at least, or that we knew as a profession had experience in this. And so, or at least parts of this. And so it's with great pleasure that I get to introduce Dr. Steve Shomo. He is a doctor of acupuncture and oriental medicine. He's board certified in Colorado and Florida. He is the Wilderness First Responder, a Colorado Special Tactics and Rescue Team volunteer, and is one of the founding members and runs the Colorado Acupuncture Medical Reserve Corps. And it's the nation's first acupuncture-based medical response for disasters and critical incidents. I had a great time working with him during the flood a few years ago. So he has a wealth of experience on dealing with crisis and all of that sort of stuff. And then we have Valerie Hobbs, and I've known Valerie. Valerie actually helped me get into Southwest Acupuncture College many years ago. And she is just a wealth of knowledge of procedures. She's a doctor as well. She's been practicing for 25 years. She's currently the director of the postdoctoral programs at the American College of Traditional Medicine at California. And she is a grateful recipient of a lifetime membership in the Acupuncture Association of Colorado. And anytime I have any questions about clean needle technique or clinic procedures, she is the person I contact because she ran the clinic for so long at SWAC and is just up to date on all of that stuff. And so with that, I give you to Dr. Steve Shomo and Dr. Valerie Hobbs.
Thank you, Stacy. I guess I'm going to get started first with this. So do we have our slide presentation? you guys hear me?
And did I forget to introduce Lara Lee?
Oh, yeah, hi.
Well, let's do that first.
I'm sorry.
No, it's okay. I take
struggle.
absolutely no offense. It's fine.
I'm trying
I'm
to
very
struggle.
boring as a job, so you know.
Well, Lara Lee is our fabulous lobbyist who has been hired by the board to us at the government level. And she has several key relationships with people in government and DORA and the governor's office, and has been helping us kind of understand and interpret what is actually being presented by our government, because as we can all atone, sometimes their wording is not exactly very clear. She has 20 years of successful business development and operations. And yeah, she's just gonna be kind of, as she has been, working with us as a liaison between us and the government. And there, I think I introduced everybody finally.
Okay.
All right. Once again, thank you everyone in attendance. Kind of the goal that we have here is to kind of get everybody in line with some of the best practices as we look forward into reopening, what we need to do within our office space, what we might need to do with patients, within ourselves as well. So we'll be kind of going through all of that and then answering any questions toward the end that you guys might have. Can we get the next slide, please? So we want to start out, we recognize that there's a lot of reasons everybody wants to get back to work. This is a pretty scary time for all of us. You know, whether it's economic hardship, being able to provide for the patients that we currently have, as well as there's a lot of people that are interested in providing the care for those that have been working on the front line, the nurses, the doctors, the EMTs, the people that are involved right there first and forward. We also have our own personal, physical, mental, emotional, and spiritual well-being that is addressed by us being able to get back to work and care for those around us. But we always have to remember that when we took on this, you know, initial aspect of providing our medicine, that we always went from a standpoint of doing no harm. And that's one of the most important things that we have to keep in consideration as we move forward and reopen our practices, the effects it has on us, our patients, as well as the community that's around us. Next slide, please. Can we get the next slide? Thanks. So when we start to look at how we're going to reopen, there's a lot of confusion that goes on, and hopefully by the end of this meeting between Valerie and Lara Lee, we'll be able to have a little bit better understanding and clarity as what happens in this process. But we know that the state of Colorado is lifting this stay-at-home order as of April 27th. According to DORA, there has been an extension to that to May 1st. As long as we're continuing to use best practices, and that's what we hope to clarify here. But you may also know that there are certain city and county regulations that have extended that component into even May 8th, or some of it may even be beyond that. Let's go ahead and next slide. So when we do look, next slide, please. When we do look at how the governance works, we have to remember that the state initiates a lot of this information. Our licensure differentiates that, but we also have, where every disaster begins, it's at the local component. So the local health department plays a big part in that. And what that really means is that if you've got your practice in Denver, you're extended to that May 8th component. If you're in a different county, that may lift earlier or it may lift later as we see this open up. So next slide, please. And I think Lara Lee will probably have a little bit more updated than when we made this slide, but we know that the current delays right now have been with Denver, Jefferson, Boulder. Both Adams and Arapahoe counties have all extended that order until May 8th. There is a link provided at the bottom of the slide. This gives you access to see what your local health department is, and you can contact them directly to find out that additional information. Next slide, and Valerie, I'll let you take the reins for a little bit.
Okay, thanks, Steve. there is an advisory that was put out by the C&T committee at early in March as we were all considering whether to stay open or not, and before orders came down. So I'm going to send the link to that advisory. And I want to give you some new information about what we know about this virus. So I'll put that link to this study that just came out yesterday. Oops. Okay, so what we know is there are a lot of questions about fatality rates and infection rates, but what we really do know about this virus is that it's infectious, and infection control has not changed just because we're reopening. And in fact, CMT procedures have not changed. What has changed perhaps is a little bit more about what we know. And it is still the duty of the healthcare provider to keep their community safe and to follow local directives and directives of medical facilities. So some of you may work in a medical practice or even in a hospital setting, and if they have increased criteria, then you have to follow their criteria. We did, as a C&T committee, and I want to carefully preface that what I'm presenting today is updated information in the last 3 days, which is extraordinary. In that Steve and the association actually kind of put this together in a very short period of time. And as you all know, information is coming out very rapidly. So the C&T had an advisory to safety plan, and we are currently in the process of updating that plan. So everything I'm going to present, if it's not based on that original document, is just from my own knowledge and not from an official committee. But in that safety plan, what we did is we wanted to recognize the clinical decision-making capability of practitioners. And so we created a decision tree so that you could think about your settings in which you work, the availability of any needed personal protective equipment, and what your disinfection procedures were, and then to use your judgment because you really are accountable for your decision-making. This next point, I think Steve will talk about a little bit later, but I think we all need to consider the mental, emotional health as we come back from this, because frankly, in this particular period of our lives, although there are definitely class differences of the impact of this, everyone has been impacted by trauma in this event. And I think that most of you as small business owners know that all too well. Next slide. Okay, so the requirements of the governor's order were to only open when you have an officially announced date, and when the requirements of those orders can be fully implemented, and when you can safely reopen, and when you choose to reopen. Thank you. Just a few facts. I think this is old news. The World Health Organization issued a public health emergency declaration January 3rd. The earliest confirmed case of an active infection was travel related. It was in Washington State on January 19th. We now know in this last week that the first death was actually February 6th, and that was a community spread infection that was not travel related or known contact with an infectious person. Next slide. Thank you. So now what we know, particularly from the most recent studies, is that the virus that causes this infection is shed in high concentration before symptoms appear. And I'm gonna post a couple of statistics for you from the New England Journal of Medicine study. This is the conclusion, and this study was done in a nursing home setting. So there hasn't been a single study that's been done on a large population center where you go out and you test everybody in the population, because there hasn't been the availability of the tests. So all the studies that have been done are extrapolated, and all those studies are kind of extrapolated from smaller sample sizes, and some of the methods that they gathered them are in question. So we know that. But what we know from this new study is that there's no question that the virus is shed in high concentration before the symptoms appear. And in the chat, I posted a nursing home study. So these are confined individuals, which may not be the same as your community individuals, and they're elderly. However, the testing on shedding the virus is probably not related to age. They came in twice. They came in upon a first evidence of infection in the facility, and then they came in a week later. And what they found was that quite a number of people who did not show any symptoms at all were testing positive for shedding the virus. And that within about a week, most of them showed up with symptoms. So from shedding the virus to onset of symptoms is a median of 4 days, a range of 3 to 5 days. So a lot of people who appear asymptomatic are going to end up being symptomatic in a short period of time. And people continue to shed the virus even when they have very mild symptoms for quite a few days into the infection. So this is a long range of time that people are shedding a virus. And the thing about shedding this virus is it's really higher concentration in the nasal cavity. When it's in the nasal cavity, that means it's a lot easier to transmit in droplets. Other diseases like influenza are in the lower respiratory tract and are spread more by coughing. So it's just a lot easier to spread this one. And that's why we're seeing a little bit higher community infection rates. What this article also says, there's a companion article in the same issue that talks about that because of this data, screening by temperature and symptom tracking alone is not adequate. So it's important to do that. However, you have to realize that a certain number of people are not going to have symptoms and they're not going to have a temperature and they still have the virus. So the recommendation in the New England Journal of Medicine is that face masks are now required by everybody. I think Steve will talk a little bit later in detail about face masks. Next slide, thank you. So what to do, and these protocols are really important because this is what you should be doing as a clinic anyway. This is in the CNT manual. And it's sort of best practice. So you need to hold a safety meeting. Even if you're in an office all by yourself, you hold the meeting with yourself and you keep minutes of the meeting. And it may be that you yourself is present and you yourself adopted the document, but document that. That is actually an OSHA requirement. So this isn't about COVID-19. And this has to be updated at least annually. So it's important that when you decide to open up your clinic that you create the paperwork framework for your decision making. Then you need to assess your clinic setting and your clinic protocols. You want to assess the use of PPE. And then you need to implement or maintain your infection controls. And again, you need to document. And so we'll talk about our suggestions for how to do that. And then you want to stay informed, particularly about this virus. Who knows what's going to happen 2 weeks from now? We don't know. I posted in the chat a link to an organization called NACHO. This is the organization that keeps track of all the local public health departments. And so you can use that link to find your local public health department. Now, I did this yesterday, and some of the local public health departments in Colorado, if they're very rural, may not even have a link to COVID-19 information. And therefore, you're going to want to defer to the state public health department. Let's go to the next slide. Okay, when you're looking at the office space, when you're analyzing your setting, you're going to want to think about the entry to your clinic even if it's in a common space in another building. You want to think about your treatment space, if you have a dispensary, and if you have any separate staff areas. And what you're thinking about in terms of those spaces is how you're going to conduct screening, how you're going to enforce social distancing, how you're going to provide hand hygiene, and how you're going to implement surface decontamination. This is kind of an important point for our offices because we have to look around in a new, different way and think about places where viruses might be living, that people can touch, that they might get infected by that route. Next slide. Okay, in terms of screening, screening actually begins with visual and audio alerts on your website, in your voicemail, posters, anything that you use to advertise your practice or where you're doing appointments. You should have certain visual and auditory alerts. So at this point, we are suggesting that you probably, maybe in some medical facilities you do, but in many private practices, we're not thinking that you do. You may not have the setting of the material or the PPE to treat known positive COVID-19 patients until a period of infection has ceased. And you certainly need to pay attention to any symptomatic patients. So you want to make sure that your patients understand that if you do the screening and they come up with symptoms, you're not going to be able to treat them. You want to alert people that you are going to practice social distancing procedures and how you roll that in your clinic. You may go into more or less detail. At least having a poster at your entryway is a good idea. And then you want to remind them that they should come with a face mask. And I put pen in here, although I don't know that anybody is ever writing checks. But if people are filling out paperwork, you shouldn't be providing common pens unless it's a brand new pen with your clinic name on it and they take it home with them. Next slide. So the considerations for the screening, you have to do the screening upon entry. So the thing you have to think about is if you had someone who starts to come into your clinic and you're doing your questions and they say, yeah, actually I've had a fever for a day, and you take their temperature and they have 100-degree fever. You have to think about how far did they get into my clinic before I found that out, and who was potentially exposed at that point. So you have to set up your screening upon entry into your space. And you do have to take people's temperature. You do have to ask them questions, and some of those questions should be about some of the atypical symptoms like nausea, vomiting, diarrhea. And they should perform hand hygiene on the spot. So that means if you have easy access to a sink with soap and water, that's great. But that doesn't mean that they walk into your office and down a hallway and then wash their hands. This is upon entry. And so you may have to supply some kind of a hand sanitizer. And if they do not have a face mask, you need to provide some kind of covering. Next slide. And then you have to look at your office space for social distancing. So you have to look at the entry to your clinic. Are they distanced from other offices or other businesses or from each other? Do you space out when people come in? How are you going to accomplish that? And you have to look at your treatment spaces. The minimum distance that patients have to be away from each other is 6 feet. You have to look at your staff spaces, because that minimum distance from a patient to a staff or staff to staff has to be 6 feet. And in some cases, depending on traffic, you may have to consider placing barriers like you've seen at grocery stores between patients and your staff that may interact with them. And then you have to enact other procedures to ensure distancing. So let's go to the next slide. So some of those procedures that you can consider, and some of these you really, you are required to do social distancing. You are required to create procedures and then follow them. Whether or not these fit your situation or not you'll have to use your clinical judgment. But you should use telehealth, and one of the suggestions I heard, or maybe do phone intakes as much as possible so that you limit the time where a patient is actually just sitting in your office talking, for both their exposure in your office and for your exposure to the patient and their exposure to you. You might ask patients to wait in their car until they're directly taken into a treatment room. I don't know how long this is going to go on or how hot it could get, but that might be something you want people to be prepared for before they come in. And then I think you need to think about your community, because what if people don't have cars? What happens? And people should not accompany the patient. So you should encourage, again, on those visual and auditory alerts before someone comes in, that unless a person needs assistance in ambulating, they really should not be bringing other people. And this is a tough one. I have seen, you know, it isn't like you can have any other care for children, but for the length of time that people are in an acupuncture office, kids really shouldn't be in cars alone. You have to think about it. You physically mark the space inside your clinic. So that means that if you know, just like those tape lines you see in grocery stores, you may want to do that. And you may want to consider doing curbside delivery of herbs. So if you have a acupuncture and herbal practice and you've treated the person and then you're going to make up a formula, they shouldn't wait around in your clinic. If you have other options for them. Next slide. In terms of hand hygiene, you do need to provide posters so that people can see that they need to wash their hands. It really does need to happen that people, when they come into your clinic, that they're just going to wash their hands. The hand sanitizer has to be a minimum of 60% alcohol. And you should consider putting it throughout the space, including treatment areas, not just at your entry. And you can use soap and water if they have immediate access to that. And then you want to practice hand hygiene per CNT. So all those rules still apply, and there's going to be some additional ones I think Steve will go over when we talk about PPE. Next slide. And I can see a whole bunch of really good questions, and please keep posting them, because I'm sure somebody's tracking that we make sure that we talk about them. But I think we are, as I'm glancing on it, going to hit on almost all your questions. Cough hygiene, you need to also provide posters on cough hygiene, although face masks are going to help a lot. But you still should be providing some tissues and no-touch waste receptacles. Next slide. Surface decontamination is an upgraded issue for us with the advent of COVID-19. Although most of the literature suggests that infections are social, that it's person maybe to person or quite close contact, we honestly do not know. And there is enough question that we have to assume, just like you assume that any person, because you can't tell when you look at them, has a bloodborne pathogen, we have to assume that any person can potentially be infected from a surface. So we have to take care of our surfaces. So again, you have to analyze your setting. And one of the things about your one of the things about your settings is that if your furnishings have a lot of cloth coverings, like you have upholstered chairs, you need to think about it. I know in some settings that's what you have, and that's what you need to do to open. So you may need to cover them with something that can be changed regularly. Or in a waiting room, maybe you take them out, or you make sure that people aren't in a waiting room. But furnishings, cloth, you can't disinfect quite as well, although there are some products for soft surfaces. So you can search those out and use them. But here's a really smart thing to do, is to minimize the non-essential objects in a treatment room. So if you have, you know, I don't know, pulse pillows and decorative items in your treatment rooms or in places where patients are going to be in close contact with them, maybe it's time to go more Zen-like and remove them. You need to put your clean laundry away too. So if your laundry is in an open shelf in a treatment room, that's a potential area for contamination. So if that's your setup, you need to put it in a cabinet or in a sealed storage container. And then the most important thing is just create a checklist for cleaning all the items in your treatment room and in fact in your facility. Okay. All hard surfaces you need to clean and disinfect with an EPA registered disinfectant that's good for the coronavirus. Maybe I'm gonna rely on somebody else to put this link in the chat so people can see it. This is the updated site where you can look through the list of things. And one of the things that you want to pay attention to is there's going to be, you'll see a table on that site, and that table will have the brand name, and then it will have the contact time. So some things that we may be used to using require a contact time of 5 to 10 minutes. And so what that means is that when you use that product, whatever you use it on has to be wet for 5 or 10 minutes. This is why in most schools you sprayed something on a treatment table and you might have wiped it down at first, but then you sprayed it on, you let it sit. And you let it sit for the amount of contact time or dwell time. So when you're looking at disinfectants that you can use, and frankly I think there's information out there about whether or not you can use a diluted bleach solution or hydrogen peroxide. So please do pay attention to what those sources are, not from the internet, but from the EPA or the CDC. And you have to look at contact time or dwell time and whether or not it's appropriate for the surface you're going to use it on. Next slide. This was a hard thing for me to find out in the last 3 days, is to establish a frequency of cleaning according to how often the surface is contacted. So I put actually 2 sources of information for you, and this is about just community disinfecting a facility. And the one that I found that was clearer than the others was from the New York Health Department, not from the CDC. And so these are 2 places that you can go and look. I could not find, as much as I tried to, any definitive source that told me when actually to clean everything. There are some things that are going to be quite obvious that you're going to clean them after every patient contact, and we'll get to them. But then do you clean things once a week, once a day? The regulations say that you clean things regularly and sort of at an appropriate interval. So we will talk about that as we talk about specific situations. However, what I will say is that you need to put this in your procedures, how often you're going to clean things, and you're going to clean some things more often than others. Next slide. Okay, so your treatment table or any surface that's touched by a patient, you really need to clean it after every patient. And so that means doorknobs, checkout counters, sinks if your patients have used the sink, so the handles, etc. Think about handles of hand sanitizer dispensers is something we don't often think about, but your patients hitting that pump with their bare hand, and sure, they're cleaning their hands, but who's cleaning the pump? So you do need to think about that when they use those items. The recommendations in a treatment room where patients are coming in and out, including the floor, is that all the surfaces at the current time are disinfected daily. And then anything that's frequently touched by staff would be daily, so computer keyboards, monitors, phones, etc., or more often as needed. And then things like your office or dispensary surfaces and floors, the best recommendation I could find was weekly. Next slide. Okay, there we go. Okay, in terms of how am I doing on the number of slides? Somebody may need to wave at me when it's really Steve's turn. In terms of laundry, you can't use any laundry or anything cloth or anything that has soft surfaces for multiple patients. So if you've got a table liner or pad, you can't use it. Even if you cover it up with something else, you really should not be using that stuff between patients at the current time. No blankets, no sheets, gowns, pillowcases. You're all going to change all that out for each patient. There has been a question about in places where patients are close together, like a community acupuncture setting, how about hanging cloth room dividers? And I went down a big rabbit hole with this one. And it was really interesting. You really have to see a manufacturer label for the frequency of washing of these commercial products. You could look right now for antimicrobial hospital curtains, and none of them have been tested with COVID-19. They've all been tested with bacteria. The study that I saw about hospital curtains as room dividers was that they found some pretty nasty E. coli, MRSA, C. diff on those curtains within a week of hanging a clean curtain. So, and that's bacteria. Then we're not talking about COVID. And it just depends on how people are around those curtains. I mean, you can imagine a situation where somebody has taken their mask off for whatever reason and sneezed and coughed and they're right into the curtain. And so there you are. But there are some fabrics that are antimicrobial, and so the best advice at this time is to look at the manufacturer's recommendations for a frequency of washing. Next slide. So here's the recommendation I would give you is create a checklist for cleaning after each patient, and create a checklist for your daily or weekly cleaning. I would keep these separate. And I would make them into a grid so that you have a list of items you're going to clean and how you're going to clean them. And then you have grids where you can write initials and dates. I would put that piece of paper in a place where it's not going to get contaminated. So on the back side of the cabinet door, or on a clipboard that's hung somewhere outside of patient traffic. And then literally when you do that checklist at the end of a patient treatment or at the end of the day, you actually look at each and every item and you initial it and you take it seriously, so that it isn't something that you're doing just, you know, like, oh, okay, how many times did I clean this room today? I'm going to fill it out at the end of the day, because this is not normal procedures for us, and you can forget something quite easily. And this becomes part of a log that you can keep, and you should keep and store as just part of your annual safety practice. Okay, next slide. I think, Steve, you're up.
All right, so now we're going to kind of switch gears a little bit and talk a little bit about the procedures, as well as looking at some PPE. And hopefully this might answer some of the questions I know people have been posting in about what types of face masks and so forth. When it comes to PPE, as we know, resources are very slim when it comes to this. So we're going to talk a little bit about that and what you have available to you. Currently, right now, the use of eye protection is kind of your choice. It is being utilized, either eye protection or a face shield or goggles, when working with a COVID-19 patient, as well as wearing a gown, and then the rest of everything else. But as far as we're concerned, the minimum is a face mask, preferably is a surgical face mask, which means that we're not able to use cloth ones. And we'll go into that, whether the patient can with that. Gloves, again, this is something for a lot of people, it is kind of foreign as to wearing gloves from an acupuncture standpoint. I work in a hospital setting, and many times we are required to wear them regardless. So it's something that you might want to get used to, being able to function and work with them in that regard. The other aspect as far as PPE is what you wear in your clinic, and we'll go in depth with that a little bit more. But we talked a little bit more about decluttering our space. The same thing can be for you. What jewelry do you wear or have on? Because that can become a contaminant as well. So keep that in mind when you're dressing for your clinic. Next slide, please. So this gives you an idea as far as face masks begin. Patients can wear a do-it-yourself cloth mask, which most people have found or made or purchased some way, shape, or form. For us as healthcare providers, it is required to wear a surgical mask. Some of you may have N95 masks. Those are reserved for treating that COVID-19. We have some of them in our office, but we did donate those to the front line and then remain to keep surgical masks for us as providers. Next slide, please. Currently, face masks, because they are limited in a resource in most hospitals now, they are having to reuse those surgical masks for up to 7 days. They are being recycled, they are being resanitized. The key factor is looking at, as long as they remain clean and dry, there's no visible defect, tears, or anything destroying the straps, and you've been doing proper taking on and off with that mask and not touching that, you can reuse that mask. So one of the questions that comes up, do I have to change that mask every patient that I'm with? No, you can wear that mask for the day, you can wear that mask for up to a week, providing that it still remains without physical defect. So kind of keep that in mind as we go through the rest of this. Next slide, please. A lot of times this is new for a lot of acupuncturists in, how to take on and off. I did look for a couple YouTube videos that may be out there and how you remove them. Most of them were more around N95 masks, as well as they're showing you how to put on gloves, they're showing you how to put on a gown and so forth. So please feel free to research that a little bit, but understanding that, you're removing from the ears, you're not grabbing and pulling it down here to talk and pull it back up, because once you've touched that outer surface, you have contaminated the gloves that you're wearing as well. Key factors to remember is you wash your hands beforehand, put those gloves on. Now they're clean gloves, clean mask can go on there. You want to avoid touching the interior or as much as the exterior, and use those straps to place those on, or ties that go over top. And then once again, if you aren't wearing the gloves, you need to rewash hands afterward before you begin with the patient. Next slide, please. As far as gloves, again, like I mentioned, you have to find your preference size-wise, what works for you, as well as the type of gloves. I found in my own practice using the nitrile gloves work best for me, not only for acupuncture, but as well as injection therapies. A lot of times people will find going down in a size that you might normally wear gives you a little bit better dexterity, but they do need to be worn in between, because that is a source of contamination and spreading. And I think everybody probably is familiar with, being able to put on and remove gloves. We kind of do that inside out, one glove inside the other, and then place those into the waste receptacle. Again, hand washing becomes key factors. If you don't have sink and soap and water, the next best thing that we use is that hand sanitizer. The other thing to think about with gloves, I know there were some questions going in of, whether I'm using laundry or sheets on my tables, or I'm using paper. Regardless of that, gloves need to be worn when you remove those sheets or remove that paper, and then they go directly to that next receptacle, whether it's that laundry receptacle or it's going to be the trash receptacle. As well as gloves should be worn anytime that you are cleaning and disinfecting your treatment rooms or your office space in general. Next slide, please. As far as our clinical apparel, like I mentioned before, an isolation gown is not needed unless we are working with or exposed patients with COVID-19. So wearing your clinical coat, or a strong recommendation, of course, is wearing scrubs, because they're easier to clean. They are designed for that specific use. Another aspect is to keep in mind that you may want to have an extra pair of clothes or scrubs that are on hand with you in your office in the case that there is an exposure, or even a thought that there was, that you can go ahead and change those clothes. As well as think about the practice of when you're returning home, to remove those clothes, have a place outside where you can take those out so you're not exposing anything from your clinic back to your family. Next slide. So try to put together a little bit of a protocol, when we look before we open, as well as once we start getting into those open procedures and doing treatments. Key thing to remember, we said before, to do no harm. So we need to make sure that we are following universal precautions. We need to assume that every person is a carrier of COVID-19. And that's where you have to start with your thinking process. You next have to think about, is your facility been cleaned? So planning ahead before you're seeing patients, doing a deep cleaning, a decontamination, a disinfectant before you even see is an important factor. As well as wondering, are you actually equipped? Meaning, do you have enough PPE for yourself as well as for your staff? And is that sustainable? How long can you utilize your practice with that? Because remember, these resources themselves are scarce. It may be a month or two before you're able to replenish that stock that you have. So you need to keep that in mind before you even open. As well as, like Valerie had mentioned before, having that safety meeting and understanding and putting all this together in a documented place so that you have that procedure to follow. The other thing to look at is the access for hand washing or sanitizing for yourself, for your staff, as well as your patients. I think I saw, a question that had popped up earlier. Your office space may have, a main entry into the building, and then a person's got to travel down a hallway and get to your office. Now you've got to keep in mind, now you're bringing that patient in and possibly affecting and exposing other people in that building because they're touching that front door, they're touching that elevator button. You've got to keep in mind that that has to be part of your process as being that provider. The other thing that came up is payment exchange. If you can go to a contactless payment procedure, that's the best way to go. Have that done online beforehand or over the phone when you're doing your screening. That way, or if they're an insurance patient, you can bill afterward. So that way there's no exchange of a check, there's no exchange of cash or anything like that. But if you can go to that type of procedure, that's going to be the best way for before opening. Next slide, please. The screening process, when we talked about with patients, should really start about 24 hours before. So what does that mean? That means calling your patient on the phone, talking with them, having that question factor. Are they experiencing any fever, any respiratory issues? Those are the two main questions that we need to ask at this point. The secondary is that GI factor. They're finding that anywhere from 20 to 30% of the COVID patients do experience some type of GI. What you need to remember is that this person can still be infected and not show a fever or respiratory issues. So please keep that in mind when you are screening your patients. Now, the next step in screening is going to be that day of service. This is when we want to do this outside the clinic. We want to minimize the amount of contamination that goes into the clinic. So we're taking the temperature before they come into our clinic space. Now, some of you may not have this already in your practice. Some of you may not be taking vital signs of your patients, but a thermal scan thermometer is the best way to go. There are contactless, but they are difficult to get a hold of now. If you have one that you are scanning and then touching the patient to that skin, that has to be then part of your decontamination process as well. That's got to be cleaned right after the patient is done. Hand washing or sanitizing should be completed before they enter to your clinic. So if you don't have a sink that's readily available there, you need to make sure that you have a hand sanitizer station set up outside your office space. The other thing you want to consider is when you are screening your patients, tell them to wear a cloth mask or bring a mask into that appointment. But you have to be ready for the patient that forgets theirs. And then you have to ask that question, what do I do if they don't bring the mask? Am I now going to give out some of my supply that I have to treat other patients to be able to supply them? So keep in mind that resource and what you will do if that patient shows up without one. Next slide, please. Now, the other thing to consider when we are looking at treatments as well as schedules is your treatment space and how you position that patient. Now, that patient's going to be wearing a face mask during that treatment. So how do you feel, or how do you think that patient's going to feel being in a face down position, in a cradle with a mask? Or if they're taking off the mask, we're increasing greater risk. If they start to drool on the floor, do you have carpet? Do you have a surface that can be cleaned and decontaminated after that? So keep that patient positioning factor as part of your treatment protocol, whether it means that you're doing only seated or you're only doing face up positioning for these treatments during this time. Eventually, we can get back to that point where we can do anywhere that we need to. The other thing as far as treatments goes is scheduling. This disinfecting process is going to take time in between patients. So allow yourself a minimum of about 30 minutes between your appointments to be able to do that cleanup. Cleaning those doorknobs, the light switches, the hand pumps, everything that patients touch. And don't get in the habit when you are cleaning that, oh, they didn't go to that place, I'm not going to clean it. No, you got to clean the entire thing every single time. And that's why that checklist becomes so important to be able to follow through with. Another factor, in my outpatient clinic, I run upwards of 3 rooms at a time. Something to think about. We're told, let's look at 50% capacity. Our equivalent to that would be to only run out of 1 room rather than multiple clinic sites. This also makes it easier for you to kind of manage and control that aspect, keeping that area clean, minimize that and that patient movement to single rooms only, rather than having to go to multiples. Next slide. Again, treatment is done. Remember that the patient's going to be there with that mask on the entire time. You're going in and out. Maintain that 6 foot of distance if you can. Basically, the way droplet procedure protocols go, that if you're anytime between 3 foot of that patient, you need to make sure that you have that face mask, the gloves, everything is on. So just make that part of your practice, at least during this time. Contactless payment is the best way to go. Think about that procedures we talked about before, following what needs to be done after a treatment, as well as what needs to be done at the end of the day or preparation the next day. And then you can go ahead and start looking at contacting and pre-screening your next day patients if you are doing things back to back. A great way to also look at that, 50% equivalency is that you may, if you were working 5 days a week in your clinic, now you're only doing 2 to start out and open to minimize that risk of exposure that's there. Next slide. Now, people have different vendors that they work with to get your supplies. Most people are familiar with places like AccuMarket and Lhasa and Henry Schein, things like that. But be aware that most of them have all of this PPE materials are back ordered. It's difficult to get them. I know that just the other day, they, I think it was Lhasa or AccuMarket had placed out that they had masks available. They were sold out in 90 minutes. So, people are constantly watching this. So again, this comes back to what are your resources and what do you have available to be able to open your practice? Can you sustain that and continue to see patients under the resources that you have available? Next slide. One of the things that we talked about at the very, very beginning and Valerie brought up, this is a traumatic stress situation for people in general, the public in general, for us as providers, for our patients. And one of the things that, I really want to stress here and to understand that, we complain a lot that we're isolated, we're stuck in our house, we're stuck at home, I can't go anywhere. But the nature of this virus is that it is very isolatory. COVID-19 patients aren't able to see their patients. They can't see their family members. They can't have friends and family there with them, even when they're passing away. So a lot of times, those frontline healthcare providers are the ones that are a mock family for them, that helping them through this traumatic and stressful situation. Then in turn, that becomes a secondary stress factor to those healthcare providers. Then they take it home to their family. So all of that kind of component, we're all exposed to this traumatic stress in some way, shape, or form. Whether we're working with patients directly, whether we're providers within our own clinics, or even at home right now and choosing not to open our practice. So understanding that when we come from a place of trauma, we know that one of the definitive factors to that is fear. And we all know that that comes from even what we see in the media and the fear that is placed on us around this. But what we want to be able to do is bring our medicine, our self-practices, our practices within our family to kind of transform that fear into what we would say is being calm, clarity, and creative, the 3 C's. not the diamond ones, but at least the good C's that we have. We want to transform that fear over. And that happens with how we work with our patients, being able to follow these protocols and these procedures to protect them, to protect us, and protect our families. As well as looking at what self-care practices that we do ourselves, whether that's providing acupuncture for yourself, it's meditation, you know, it's taking a walk and maintaining that social distancing. We want to look at those kind of things to kind of begin to transform and bring ourselves away from that fear factor. You know, if you're a provider and you feel that you have that fear based off of seeing patients, you know, don't even go there. Don't start there. That's going to perpetuate that. Wait until you're ready. You have all of these factors into place before you return into practice. And I know that, you know, it's tough. It's hard economic times for people. But we want to make sure that, you know, you feel that you're ready, and then follow those state, local regulations that are there. Last slide, please. When we look at finally, you know, referring out and kind of some new things that are out there and available to you, you know, if you feel that there is a sign of potential infection with a patient, of course, they need to be referred to Western providers. At that point, understand that testing basically doesn't happen just because of that. Testing now currently in Colorado is being utilized for those that have symptoms, but then also require hospitalization. The other form of testing that is being done is done with the healthcare providers that are working there. So understand that basically what's going to happen is that person needs to go into that 14-day self-quarantine, and then they'll go to that next level of care if they're requiring that hospitalization. Therefore, they'll get the test. We know, and you've all seen in the news and things like that, you know, the nasal swab testing, there is tests available, but there's not always the materials. The nasal swabs aren't always available. So again, there's that battle of resources that are there. Recently, in the last 3 days, there is a test that was brought out by National Jewish Hospital here in Denver, and it is an antibody test. It is available to you without a physician's referral. There is a cost of that of $95, and as far as I know, I believe that insurance doesn't cover that. So just kind of keep that in mind. That's just an option is there. As we move forward, we're probably going to see more and more of the antibody tests being available, so we can determine a little bit better how the community is responding to that. I think our last slide, and I think we're going to open it up to some questions that we haven't answered or addressed as far as the presentation goes.
Okay, hi. So this is Elizabeth. I've been tracking questions. One of the question that's come up the most is questions about what to do about clinics with carpet flooring and what they can do about that.
So far as I know, there has not been any mandate that you can't have carpet in a medical office treatment setting, but you do need to recognize the drawbacks of not being able to disinfect that carpet. We don't know if you're picking up this infection by walking across a floor or it's picked up by your shoes. This we do not know. You may want to look into how often you should be steam cleaning that carpet. It certainly is probably a good idea to do some deep cleaning before you open, and then to research the protocols and figure out how often you need to repeat that for the treatment areas. But there just isn't a straightforward answer to this question. A straightforward answer would be if you could change your flooring, it's probably a good idea, but many people are not able to do that.
Thank you. And then another question, we've gotten a lot of questions looking for specifics about face masks. There were concerns about cloth face masks and also what other types of face masks are considered acceptable, and then also what to do with the, I think that it's called the N9 face mask, what the rules and regulations are around that.
Right, I tracked some of those questions. I'm going to put into the chat again the link to the Medicaid requirements that flat out say that healthcare providers should be wearing at least surgical masks.
Correct.
And so there is that information for you. I acknowledge how difficult they are to get. There was a question about, well, does that mean I can't open? You have to use your own professional judgment. All I can put in front of you is that this is the requirement for healthcare providers. There is a lot of information out about what cloth masks are okay. I also put in the chat a very recent article that looked at that it's probably better if cloth masks are used if they have different kinds of material. 2 different kinds are much better than a single kind of material, and so that you can look that up. Steve, there was a really good question about if someone is immune compromised themselves as a provider, should they be using an N95 mask? And a second question I'm going to toss to you was, what about those N95 masks from China that have, you know, I don't know if they're like
KN95, a different one. My understanding with those, and again, you know, this is something that you're going to need to know your source, where it's coming from. Is it a reputable provider and vendor that you're getting those from? Keep that in mind. My understanding is that the KN95 is the same as what we use here as being the N95. So with that said, yes, someone who is immune compromised themselves as a provider should be wearing that N95 mask. Otherwise, you know, cloth masks are not good. They're great for you going to the grocery store or whatnot, but as a provider, you need to have that surgical mask component available. So when you look at that too, and I think I mentioned before about the resources that are there, you know, I've worked in integrative clinical settings, so, you know, having gowns and having respirator masks and surgical masks is part of what we have in the clinic. So fortunately, I have some of those things. So, you know, thinking of this as being an afterthought, make that part of now your supplies once this is over, that you have a box of surgical masks that are in your office, specifically as this goes. We're going to see more and more of these outbreaks with different types of you know, transmittable diseases. We need to make sure that we are following those infectious controls. So keep that in mind. If you don't have it now, once those resources are available, this needs to be part of what you do in the future.
A follow-up question is whether or not staff in a clinic need to be wearing surgical masks.
Yes, they do.
And I'm just trying to think through the process, and of course, I know it's all overlaid with not being able to open in a time of short supplies. But I would consider greatly about putting employees in a riskier situation.
Right, and that's the same thing, you know, you have to decide, you know, the way your office is set up may be different. You know, in the outpatient clinic, our administrative offices are separated. They have a glass window that separates them from the rest of the clinic space. However, you know, if we're going to plan on opening that, we want to minimize the effects to our staff as well. So that has to be part of your process. Are they going to be risking now their family, their friends, and so forth? So keep that in mind when you open.
I think there was another question, but I'm not sure. There are a lot of, you'll have to investigate sources. I know this is frustrating. I'm kind of, I acknowledge it. But these really are the criteria that are printed for healthcare providers.
There also is a lot of questions about using what materials, sheets, or like coverings or barriers need to be out of, if they need to be cloth, plastic, etc.
Steve, do you want to take that one, or?
You can go ahead.
It doesn't have to be a specific thing, but if it is cloth, it has to be changed for every patient contact.
And so one of the things that, that Valerie had mentioned before, you know, a lot of us, you know, may have heaters on our beds. You may have, you know, egg crates or additional mattress or pads. That has to be removed because it can only be used for that single patient. So we can't have multiple patient uses for the same thing. You know, if you're in the habit, I've seen it happen in clinics, that people just use a sheet and flip the sheet over. That's not done anymore. That patient use, it goes directly into the laundry.
There was a comment floating about what some hospital institutions are doing about staff, and I just think you're going to have to, and the fact that some staff are wearing cloth masks. I don't know where they work or what contact they have with patients, so I think it's just, you have to you have to put all that information into a thinking process about your setting and your procedures, and then make your best decision.
And if you are working out of a hospital, I mean, I do 2 to 3 days a week in the hospital, and you know, their guidelines are different. Their procedures are different. I follow what the hospital establishes as the protocol that I follow. I mimic a lot of that within my clinic space, but the idea is that, yeah, you're washing, you're screened, all of that is done before you enter that space. Even as employees, we're screened and everything before we enter the hospital space.
Okay, and I don't know if either of you can speak to this or if it's relevant for the town hall, so feel free to say we'll pass this on another time. But there are a lot of questions about unemployment, and if people can be considered unemployed if they're unable to access the masks and supplies needed. So that's a question that's been floating around.
That is such a good question. I don't know.
Yeah, that's a hard call, because you know, you don't have the materials and the things that you need to provide the service that you do. Does that extend that, you know, time frame that you're unable to work? That's a really difficult call.
Right. There are a couple of questions about sanitizing surgical masks, and there are directives out there about what you need to do that, how you do it exactly. Because hospitals are certainly doing that, and those protocols are out there. So if that's something you want or need to do, please investigate what those are and put that in your protocol and plan. There was another question here about, you know, what happens about lawsuits and patients claiming that they got COVID-19 at your facility. I have seen various things over the last several days about malpractice insurance, but you should contact your malpractice insurance provider, because my understanding of your malpractice insurance is that they're going to cover you if you're following the best practices and the directives of your state and local health departments. And this is one of the main reasons why Steve and I are telling you to have a safety meeting that you document, and to have infection procedures that you document, and then to have daily checklists that you document, because we don't know what patients will or won't claim in this period of time. And that's the kind of thing that if you have that in place, that will help you.
One of the other things that I've seen come up a little bit is, since we're talking about the documentation component, you know, the fact that you're making that phone call ahead of time and pre-screening your patient, the fact that you're taking their temperature at the door and doing the hand sanitizer, that all goes as a documentation. That goes into that patient record that you did that. That way, this shows that in the long run, if there is anything that comes back, you were following that infectious disease control, and it's documented in the patient's record that that screening place took.
Mm-hmm. There are some other questions about, can you put a egg crate or a sheepskin on a table and then cover it with vinyl and then disinfect the vinyl and still use it?
I mean, if you're doing this on your own, that's a risk. You know, if you need more cushion in your table, think about the table that you're purchasing. Get one that has, you know, a 5-inch foam, or it's a thicker mat with your tables from the get-go, rather than doing a kind of DIY, your own kind of stapling on material and things like that. You're just setting yourself up for a risk.
Yeah, and we may see those directives change. We don't have a lot of information about how this is spread on contact. And surfaces. And so some of the information about laundering, and again, check the Medicare document about what's required in healthcare settings right now, because I really think that reusable items must be not only disinfected, but cleaned and disinfected between patient use.
There's a question that came up on pillows. You know, if you're using bolsters in that, typically those are vinyl covered anyway. That's going to be part of your disinfectant process. The pillows themselves, for example, the ones that we use in the hospital, have a plastic cover over them that is a protective barrier, similar to what your isolation gown is. And then we're using a pillowcase over top of that. Pillowcase is removed, then that plastic coating is then disinfected the same way we do the table. And then at night, that covering off the pillow is removed and a new one is placed on for the next day. And that's kind of the pillow factor.
There was a question about disposable items and do they need to be in a biohazard red bag? As I understand OSHA requirements, biohazard red bags are used when there is actually fluid, body fluid, like, and not for typical disposable items. Those, as far as I know, those criteria have not been updated for this virus. And, but your trash receptacles themselves need to be labeled as medical waste for cleaning staff to be alerted to the fact. I don't know what local criteria are in Colorado, but so far as in many jurisdictions, once you label that, you still put those items in the trash.
Could either of you or both of you speak to the gloves situation? There's been a lot of questions about resanitizing gloves, how to use them, how to store them, etc.
So let's separate this because when you have disposable gloves, they're disposable, they're single use. There are gloves that are reusable that would typically be used for cleaning. I would say if you have reusable gloves that are okay for hospital level infection control, then you follow the label instructions on how to disinfect them.
And with that said, you know, the gloves being disposable, that is in between each patient procedure. So what that means is that if you go in and see that patient, you do your intake, you place the needles in, and then you leave the room and you remove those gloves, a new set of gloves has to go on, okay? And it's the same thing that, you know, you're not gonna go out into your office space and do your charting and leave those gloves on because now you're touching other surfaces that therefore could become contaminated or could contaminate the patient. So what you wanna make sure is that after each of those patient procedures, you are changing those gloves. So yes, you are gonna go through boxes of gloves.
There is no criteria that your gloves have to be sterile.
Thank you. And I don't want to cut off the conversation about gloves. If you have more, please add. But there are also several questions about best practices around the contact with the patient. So you have all talked about kind of the process of that, like walking into the building, what it looks like to take payment, what it looks like to give treatments. But I think people are looking for more specific details about best practices through that whole process and all of the contact with the patient in person.
Other than you're doing your screening, you have your appropriate face mask on, you're using gloves, C&T rules still apply. So I don't think there are a lot of different items for this particular virus, but let me defer to my more learned colleague, Steve.
You know, think about this, the close proximity. You know, we may take for granted a lot of times that, you know, we're doing pulse when we get right up close to that patient and things like that. Remember, we want to keep that distance as we possibly can, and we want to make sure that we are wearing gloves. I know that some people are going to have a hard time with, you know, being able to take pulse with gloves on. Does it take a little practice? Sure, it can be done. I do it a lot of times. We do it a lot of times in disaster situations and settings. We are wearing gloves at times. So that process, you've got to kind of look at what your practice is currently, the time that you spend with the patient, and then how you can best maximize that distancing or the effects of the PPE, being able to be close enough you can hear, but still be able to do what you need to do.
There are some questions in the chat about the deadlines, and that was at the beginning of the slideshow, so let's go over that again. DORA has mandated that May 1st is the deadline for acupuncturists. That's under your license, that's statewide. There are local health departments, county health departments that have said May 8th. I'm not sure I'm going to remember what all of those are. Steve, do you remember what
It's Denver, Jefferson, Adams, Boulder, and Arapahoe counties as far as Lara Lee may have some different
yeah, thank you.
Yeah, she may have some other updates, but when we made the slide, those were what had already submitted, that they were extending that delay to May 8th.
There's this question about why gloves instead of hand washing. This is a really good question, because we, as a CNT committee, we fought really hard for acupuncturists to not have to wear gloves, because we're rarely in contact with potentially bloodborne pathogens where you have to wear gloves. And we worked really hard to separate ourselves from other healthcare providers for which gloves are really necessary. I can't hardly find any updated information about PPE and gloves, because gloves are considered to be so normal for all healthcare providers that I don't think it's even coming up in the conversation amongst infection control experts that we might not wear them. So the issue about gloves is about not knowing what part of that patient's body may be infectious, or their clothes may contain the virus, or any of those other parts, so that you're somewhat protecting yourself. If you touch a patient, or any part of a patient, or any part of what a patient is touched, and then wash your hands, I suppose that might be sufficient, as long as you never touch your face, right? Or your face mask. And I've seen a lot of people wearing face masks and they're putting it under their nose. This is a thing that you might want to put on a poster, that for this virus in particular, you got to have it over your nose. And it needs to be a well fit over your nose, because that's where the contamination is coming from. So I guess the CMT committee has certainly not gone to saying you have to wear gloves, but that information is really not clear amongst healthcare providers. And I think you have to exercise some really good professional judgment about it. If you're not going to, then you're going to be doing a lot more hand washing.
Can either or both of you speak to if there are any changes in liability forms or waivers that people should be considering adding to their practice during this time?
I think that's a question for your malpractice insurance providers. I don't know, Steve, if you have an opinion about that.
I didn't hear the full question because I just got an Amber Alert that went through, so most people on here probably did as well. But what was the question again?
The question was, what about release of liability statements? Should you get them from your patients? Oh, you're muted. Steve, you're muted.
I don't know if that's fully, that's going to be something that your own liability insurance is going to have to answer, whether they feel that that's necessary or not. But one of the best ways, like we talked about before, making your best practice of documenting that you're doing all of this screening, that you've got a plan in place, you're doing this disinfectant protocols, all of those things will help protect you in that long run. But your liability insurance company is going to be the one that has to answer that definitively, whether you need to do additional liability statements or not.
Okay, people keep saying they're confused about the opening date, so I'm going to say this really. DORA says May 1. It's in your state license. If you want to go against DORA, that's up to you. Your county, if your county says it's a later date, you have to follow the later date. That's also in the DORA thing. If your county says it's an earlier date, I can't help you. They're confusing all of us.
And this is the county that you work in.
Right,
So,
and it doesn't override what DORA is saying for you for a license, as far as I can tell. There are a lot of questions about this, but that's kind of the way that those regulations roll out. So DORA is really saying statewide earliest is May 1. And some counties are saying May 8th, and frankly, other counties are having meetings like today and tomorrow. So you've got to check your local county health department site.
and it's going to be the county that your office that you're working out of. It may not be the same county you live in, so keep that in mind as well. But, this is still very dynamic. And, after we see this May 1 date and things open up, if there's an increase in a spread of the virus, that's going to be shut down again. So it may not be May 8th. So this is very dynamic and changing all the time.
And then also, can I say something? So I know Lara Lee had to leave because I think the governor is having a press conference right now to hopefully clarify some of this. So I want to thank everyone for the patience of understanding not only what Dora is going through to try to get all of these professions in line, but then also the Colorado Department of Health, all of our government officials really working together to try to coordinate the best they can. And we had to put on a webinar and we had this much challenges. Imagine what they're going through. So I think a lot of us have to give a lot of leeway. And I think that's the biggest thing Lara Lee's been trying to tell all of us is, unemployment, from what we can tell, the state is doing the best they possibly can to make sure from an unemployment standpoint, they can do what they can. A lot of it's unclear, but I don't think that's a place we should be functioning fear from, is the unemployment part. They're going to do the best they can. So I think what it comes down to us is exactly what Steve said, was we need to be sure that we're not fearful for opening. We have to be sure that our patients are to a 99.9% confidence rate are taking care of this, are not going to get the virus from us. Mm-hmm. And then we have to follow all the mandates. And as I've been going through this, the one thing that I've been clear of is Dora has emailed us exactly what we need to know. So everything else has been sort of like Lara Lee called it shopping for information. I think it's more trying to discern everything. Mm-hmm. But if you read what Dora said, it says May 1st, and that was an email to all of us. So we have to give a little bit of, again, patience to Dora, that sometimes on April 27, 28, they're going to release either further deadlines. So as of now, May 1st, definitely pay attention to your county, just as Valerie and Steve have, and Tuesday and all of us said. So May 1st, unless there's a critical, basically what was happening before. So
there was a question about a template for a safety meeting, and I don't have a template for a safety meeting, but I think if you look at, I think you can search for like an OSHA bloodborne manual, and you'll get many different sites, their example of their bloodborne manual, and there'll be a section in there about how to revise it. But basically you document the date it happened, you document who was present making the decisions, you document that they went over your protocols, you document here are the new protocols, and you document when it's up for review again. That would pretty much be it. That was a good question. These are great questions. I'm watching the chat and wishing that I could just watch the chat. You guys are really smart.
Yeah, there's also been a couple questions about thoughts around keeping the air quality in your place, in your facility. There's a question about using an air filter. Someone mentioned an ozone machine. What considerations we should have about airborne pathogens?
So the regulations that I've seen they're a lot about when you know that there's an infection, but they do recommend that you look at the airflow in your space. So if you have a treatment room where there's absolutely no airflow, it is a good idea to have some. And so even for people who are home confined, they just talk about opening a window. There are a lot of practitioners that are looking into air filtration systems. But I have not seen that mandated. What is mandated is for you to look at your setting and to consider, if you have very closed space, you should provide ventilation. But I don't know of any more detailed criteria. How about you, Steve?
No, I haven't heard anything other than that as well.
Yeah, somebody is saying something about UV lights. There are a couple of newer kinds of ways that are sterilizing masks because of the shortage of masks. And some of that is UV light. And I think there's also hydrogen peroxide aerosol. thing, but those machines, that you can't do that like in sunlight. You have to look at the machines and their specifications.
One of
You can
one of
look
the
at-
things that just scrolled on that, Valerie, people were talking about, using UV light, like CU Hospital, UC Health. My wife works for UC Health. She's part of this whole process. The UV light aspect is not the only thing being done with those masks. There is still a sanitation process. They're working with them together. There's no science data out there that says that using that UV wand or that UV machine is 100% going to guarantee that you're limiting that. They're using it in conjunction with these other methods to prevent that. So please keep that in mind.
and read materials from manufacturers, and yeah, just a wand, probably not going to do it for you.
And look at, the studies that are done. People can pay to have studies and statistics manipulated. Understand, is it a third party, that has looked at that being good documented study or research? Don't just take for granted that here it is, this works perfectly, it's going to protect you. You can't do that. It's got to be all part of the process.
There's a question about allergy patients, and yes, it's spring in Colorado, isn't it? Sneezing is a pretty atypical symptom. Coughing, you're gonna have to really look at what they did in the nursing home study. Is they looked at whether or not some of those symptoms were chronic and whether they were exacerbated or whether they were new. But keep in mind that some of these symptoms of a mild case of COVID-19 may show up like allergy symptoms. Some, not all.
There are also a lot of questions and confusions around which regulatory agencies and which policies they should be reviewing, and then what acupuncturists and their practice would be called in terms of what it's categorized in these policies and regulatory agencies. Could you maybe speak to clarifying some of the words and some of the organizations they need to look at?
I can speak to that a little bit. That's why Lara Lee was, again, sorry, that was why Lara Lee was here. And she's been, I can't tell you how many hours she's been putting into this, talking to all the different departments. I don't know enough to tell, but what we have to understand is that DORA, as we've said, DORA holds our license. And then the county public health and the Colorado Public Health are also involved. So I don't know, is there a more specific answer on that or question on that you
They
can
might
give?
be wanting to ask if you're a healthcare provider. You are.
Oh, that's right.
And
I do.
I think the legal definitions about whether you're essential or non-essential, then that gets a little twisted, but you are a healthcare provider.
And the reason on that email on Thursday that was sent, thank you, was sent out as a personal service is because DORA is definitely classifying us as healthcare practitioners and medical clinics. That's not in question. The challenge is, and has been, what do you do with professions that are doing essentially mostly minor elective surgeries, but then also are consistently breaking that 6-foot social distancing requirement?
Yeah, the DORA licenses barbers and plumbers and everybody. So I think that's probably why they put out their email like they did.
Right, but we are definitely in the medical providers, but because we're breaking that 6-foot, like a mental health therapist, but even doctors to a certain extent can really attempt to maintain that 6 feet. Chiropractors, us, we have a little bit harder time. So my understanding is most of those professions that kind of fall in that Venn diagram receive that personal service email. And Laura's spent literally 4 or 5 weeks since this has happened trying to really clarify that we're medical, and she's really worked hard on that. So I think all of us need to rest assured we are being classified as medical providers, but we have to understand that we are a little unique in the fact that we have to break that 6-foot social distancing and have skin to skin contact.
Okay, Dr. C, did you have anything you wanted to add to that before I ask the next question?
No, I think that Casey was probably best to answer that.
Mhm.
Unfortunately, I wish Lara Lee could have been here, but
Yeah. Thank you. So I just want to do a time check. I think we were scheduled to go until, was it 1:30? Is that right? And it's actually 2:30. So I wanted to see how much more you wanted to go on. And then I also wanted to just reassure the group and you all that I have captured, and I'm still capturing all the questions in the chat because I'm like there's 100 chats left for me to go ahead and capture. But I also have captured all the Q&As in terms of just the question. I have to go back and select the answers if they were submitted. And so I want to just request that time check and then a question about moving forward and then just reassuring everyone that the answers have been captured. I just don't know what we want to do with all of them.
Well, I was
Valerie,
going to go get my hair cut. No, I'm
there,
kidding.
there was
No,
one
I'm so kidding. There's 200 participants here and I got nowhere to go.
Yeah,
So-
there was a question that came up, Valerie. I don't know if you or I want to address
Yeah.
it, but cupping as part of the procedures that we do.
Yes.
So
Cupping requirements are no different under COVID-19 than they ever were. And if there's any confusion about them, we can't tell if you're getting bloodborne pathogens in a cup or not. There's a lot of controversy about that and not a lot of studies. So the CNT committee said intermediate level disinfection is required, but we really think you should be doing high level infection. And a cup is not a surface. So if you're using like a wipe to clean off a door handle, and you need to think in COVID-19 that wipe may not confer the contact time that is required for that substance to kill the virus. But for cups, wipes have never, they may be intermediate, but wipes are not made for medical devices. And the only level of disinfectant for cups that I understand is okay are those products like Sporox or the cold sterilizers where you wash your cup with soap and water first with gloves on, and then you immerse the cups in a product and you follow the label instructions for the amount of time. Or you can autoclave them, or you can use disposable ones. But that's no different for COVID-19.
Okay, so at this point, I'm having trouble. There's so many questions. I'm having trouble counting and organizing them. I'm really just at this point trying to capture them. So if I could maybe ask the panelists, are you able to see the questions that are in the answered section of the Q&A? Because if so,
Oh yeah.
Yeah, if you want to go ahead and just start going through those are ones that I've already captured into the record, so we'll keep track of them. And then
I'll go from the bottom, you go from the top.
Awesome,
right.
thank you.
Casey, can you talk about either the PowerPoint going out or the recording and how that will be available later?
I'll talk about that. The town hall and the annual business meeting that preceded it, for the most part, have been recorded. We did miss a few minutes at the beginning of the annual business meeting, but when this meeting is completed, then it'll generate a video file. That video file will then need to be processed, and we will upload it somewhere, most likely YouTube, and we will place a link on the AAC's website to make it available to all. Once we've posted it, we'll also promote that through Facebook and any other social media accounts that we have so that people will have the location of the link. And I guess as I think about it, we'll send out an email to all of the members of AAC so that they can have availability for the meeting links.
There's been a couple of questions just regarding face masks, so I just kind of want to recap that. You know, the N95 mask is reserved for those who are working with COVID-19 patients directly. Unless you are immune compromised yourself as a practitioner, it would be best to use an N95 mask. Otherwise, because we are categorized as that healthcare provider, our requirement is to wear surgical masks and not a cloth mask. A cloth mask is okay for your patient, but not for you as a provider. So I hope that kind of clarifies and answers. There were a couple questions that were in there with that.
There've been a couple of questions about laundry. Everything I've seen about laundry, if you're doing your own laundry, is that it has to be at least warm water and preferably hot water. And if I'm remembering this number, it might be 135 degrees. But there doesn't seem to be a problem with warm water washing. Cold water washing is probably not enough, but I haven't seen any studies on it either. The level of thinking in these questions is just remarkable, and I love it because I feel like we did a good job in getting you to think about your settings and think about what questions, because there's this question about do you cover your tissue box? If you have tissues out there, do you want to have a cover? But then I think, well, how are people going to get to the tissues, and they have to touch a cover, and the cover might be worse than just getting the tissue. But it's the kind of thinking that I'm really impressed with. There's a question in here, Steve, I'm going to throw this one to you. What in the world do we do about tongue diagnosis?
That's a really good question.
That is a good one.
As part of that, if you want to stick to, that's going to be what your own preference is going to be. It can be a risk factor. But what you can do is, if the patient does the proper procedures of putting on the mask, taking off the mask, looking at it, you've got to remember they're going to have to wash their hands or sanitize after that's done. Mm-hmm. It's just a step in a procedure that currently you might want to think about just using the pulse for right now. Mm-hmm. But go ahead, Valerie.
Or you can be teaching them about mask etiquette.
Yeah.
So, and that's a really good question about how you do that. Or here's another question about having them text or email a photo of their tongue before the appointment.
It's a possibility, but the lighting on them is usually not well enough to make a definitive diagnosis when it comes to that. There's a couple questions that have come up in regards to temperature and things like that. A couple people have visited their MD's office, and the MD didn't take their temperature. That falls on the MD. Your protocol is to have that temperature taken before you enter that space. As far as what you utilize, the thermal scan, the infrared thermometers, if you don't have them already, you may not get them. So you're going to have to look at that. Are you able to assess and screen your patient properly? If not, then you shouldn't be opening, because it is going to be difficult, even for Amazon, to get a hold of some of those aspects. But again, that becomes that next forethought that, all right, I may need this again in, my clinic. So once this is over and these resources are available, I'm going to make that purchase and have that for my clinic space.
There's a question about if you work in another space with massage therapists and physical therapists. I think the single document that is the most useful is the one from Medicare.
Yeah.
And that talks about what you have to do to reopen, and it's across all professions, and I can't imagine that other professions wouldn't respect that. All right, I'm not, if we're really not capturing your question, now is the time to repost it.
Valerie, can you speak to the pulse ox? I think that was an interesting.
Steve, I think you might, do you
Go ahead. Go ahead. I'm still searching.
Pulse oximeter is a pretty cheap tool, but it has to be cleaned between each patient. So look at the manufacturer requirements. And a pulse oximeter just shows the level of oxygenation. Some of the studies are showing that people are not feeling short of breath, and yet they're not oxygenating. And a lot of those people already have a fever and have symptoms of COVID. That's not typically happening with asymptomatic people. But it's one of those things that you might want to consider as just normal vitals taking in your office setting.
Yeah, and I mean, if it's not part of your procedure, I mean, yes, I'm doing tongue and pulse with my patients, but when they come in, I'm doing, blood pressure, pulse ox, temperature, respiration rate. All of that is part of my intake every time I see that patient, regardless. So for me, having some of that equipment available is there. If you don't have it, if you can get it, fantastic. Start making it part of your practice. It gives you a lot of insight as to what's going on with your patient, and then transfers over and verifies a lot of the things that we do with diagnostics as far as TCM goes.
Steve, there's a good question here.
Sorry, I need to interrupt really fast. We're going to go ahead and have our mediator wrap up her capturing the questions. So what we'll do is we're going to leave the room open so you guys can keep answering them as we move forward. So you guys are doing a great job, but we'll have her try to capture what we've had so far at this point in time. Okay?
Thank you.
Go ahead.
Valerie, you were saying there was a question?
No, I'm going to.
Is Elizabeth, are you going to wrap up or?
So I'm still here, but I'm going to just capture the remaining questions that are in the chat. And then I'm going to ask people at least right now, is your last chance to go ahead and put your questions in the Q&A or chat. I'm going to capture the rest of them and then I'm going to head out. But that means that Valerie, Casey, and Dr. and Steve, you'll all have to just go through the questions that are already there. I won't be asking groups of them anymore. I'll just be capturing them. So we'll have a record of it.
We'll have a list on hand so we can, if there are themes that we aren't able to get to, we can have follow-up to that as well. We can write articles. So this will be material we can follow up with.
And one thing that I just saw addressed, and we've been talking a lot within us, is community clinics specifically. So, I mean, maybe we'll go into that after this briefly, and then also know that this is stuff we're looking at beyond Monday.
Liz, I know that you have to go, but I think it's so important for us to address the community thing kind of head on, because there are a lot of community clinics doing great work. The original advisory from the Council of Colleges was written in collaboration with Lisa Redler, who is staying in contact with that committee and talking about other things. And honestly, it is about that 6-foot rule and limiting your traffic to 50% of what it was before. I know that's hard because I think those clinics are going to provide a need that the populace really needs. But that's kind of the directive at this time. I'm not seeing anything in our processes that we've described that can't be answered by thoughtful thinking in the community acupuncture community. And I think that there are websites for providers of that kind of business model that are doing a really good job in troubleshooting these issues. You have to be 6 feet apart.
Okay. Any more questions, or how are we doing? So I guess I think we're wrapped up. We're closed. So thank everyone for hanging in there, especially with all the technical issues. I got confused. I apologize. But we'll get this out video, obviously. Amazing information. And I think the general meeting ended with an idea that we need to work with Dora to understand how we can open as soon as possible. And I think we'll look more at that. But I think that is something we can all talk about. So if you guys want to leave, great, but keep coming to questions. What I'm hearing from Valerie and Steve and myself is we'll stay here as long as anyone wants to.
One of the questions I just saw that came up was, working in an office space with, other practitioners and providers that are there. My suggestion when it comes to that is give yourself each a day. So, if it's my day's Monday, the next practitioner is going to be Tuesday, things like that, just to limit that potentiality of spreading it rather than having multiple people going back and forth and increasing the amount of staff that's in the room. So kind of keep that in mind when you're looking at that, opening the business.
Liz, do you want to recap, end our meeting?
There was just one quick one here that someone had put in, that there's a contradiction that they were looking at of social distancing and things like that. You know, there's all sorts of things out there. You know, the 6-foot rule has kind of become the standard. But, you know, we know something like a forceful of a sneeze can travel 10 to 12 feet. So there's a lot of differences that are there. When Polis had mentioned about the 50%, and Casey, you can jump in here and correct me if I'm wrong, but the statement that he made of 50% capacity was addressing office buildings. It wasn't necessarily saying with medical practice that we have to be at 50%. I had mentioned in the presentation, an equivalent of that for us might be using a single treatment room to minimize that exposure potentiality. But that 50% comment that Polis had done was specific to offices, not medical practice.
Yes, and I confirm that in many places.
Okay, so I am going to, I'll put my video back on. I just want to thank everybody who was on the panel, and Casey for putting this together, amazing. And to the whole board really has been doing such a tremendous job. And thank you, Elizabeth, for helping to facilitate this and gather questions. So our goal is, like we've been told, we will post links to this webinar. We will post the slides with the information. We have the questions. We'll go through the questions and find out is there stuff that wasn't addressed, and if so, you know, we'll make sure to circle back with Lara Lee, with C, with Valerie, and get answers to things that might have been dropped. And I really do see that, you know, with the interest, you know, it's not like this is going to be the only time. I think that continuing to have these COVID town hall meetings in the next little while is not impossible. I think it's definitely a good idea. And the other thing that I know that has come up is this idea that's come out like, oh, all elective procedures are now open at hospitals, and so therefore that informs us to, you know, go out and treat everybody. I also work at a hospital, and I haven't been working because there hasn't been adequate PPE to warrant my being there. And even with the opening of elective procedures, they are being very cautious about those. It's the person who has not had their mastectomy because they had to wait to see what was going on with the hospitals. These are still emergent, quote unquote, elective procedures. They are carefully screening those people for 10 to 14 days before their procedure. They are being quarantined, they are being tested, and those procedures are not happening unless that hospital determines that there is adequate PPE on that day, and not just, you know, adequate ventilators, adequate medication. As you know, like fentanyl is an issue because of ventilator use. So as much as on one hand that message is, oh, we're sort of elective and so we're all good to go now, please continue with this caution. These all this information from Valerie and Steve has been spectacular. I mean, just amazing. And like I said, we're going to continue working on getting information out there. We'll find out what Polis is saying from Lara Lee. We're continuously getting stuff from Dora, and we have been interfacing with Dora. They have been provided with our CNT stuff. We are really telling them that we know what we're doing, and we're counting on you guys to do those things. Don't make us look bad. All right, and so I'm just going to go ahead and thank you all again and wrap this up. And what a way to spend our Saturday, right?
Thanks, Liz. So
Right.
now we're at the after party. So, Steve, there was something that you wanted to bring up in the after party.
There was?
Yeah.
My memory.
I think you said you would answer, you're going to answer a question live. If you have multiple treatment rooms, do you think it's
Yeah.
one at a time or alternate rooms? Give time for the droplets to settle?
I think we had covered that a little bit in earlier, but they may not have been on the time when we explained that. It really comes down to minimizing the exposure to you and your patients and where you and your patients go from there. So if that means, you got to remember, you got to stagger patients. You don't want multiple patients in your waiting room because that's just increasing that risk. So the idea would be to minimize by using one room only. And, it's not going to be forever. It's just the current situation that we're in, and minimizing those risks of exposure to you and to others, and giving yourself that lag time in between to clean. Yes, there are some aspects to community acupuncture and maintaining that ability to protect. If you can do that, that's the choice that you have to make within your own office space. But you got to remember that you've got that 30-minute time frame or so minimum to clean those spaces. I mean, all the way down to the light switches. All of those things have to be clean. And are you able to do that while maintaining and running a second room? So just kind of keep that in mind as your practices go. I saw somebody mention about bringing whiskey to the after party. That's cool.
I don't think there's enough whiskey in the world.
I don't know. I have a lot at my house.
I do too. I mean, the local, they deliver, so I'm able to get all sorts of aspects.
Okay, I'm still seeing about 100 people here that might be. Thank you. They might.
Hi guys. No, I just jumped back on.
Oh, you're back.
We needed you, Lara.
Well, I was just talking to the governor, which is always fun.
And what does our friend Jared have to say?
That he in no way meant to denigrate our profession by calling us only personal services. He understands that we are a group that bridges the medical critical, and that's where we live in Dora. And also, so I just jumped off because now it's all about hair salons and stuff, and I'm just like, I'm so done. So I wanted to get back to you guys. So yes, he apologized if there was a problem with that particular release. And he in no way meant to denigrate, so good statement. He also said that public information is going to come out on 4/27 about how to reopen, and what he sees us as is we cross some borders here from critical medical care all the way to personal services, right? And so more guidelines are going to come out on the 27th. They're going to be working basically until they collapse on figuring that language out. But and pardon me for being kind of in and out of the thing, I'm reading my notes. Personal services v. medical new guidelines are coming out on, again, the 27th. Best practices for us are to assume May 1st. Okay. To resume practice with, as you guys have done such an incredible job of describing, and frankly, I was on both. I had these in for you and him, so I was listening to as much as I could of both. I'm a lobbyist. My head is crazy. So, but May 1st is looking like the reopen date.
Except if your county said later.
Exactly. That was the next thing. He said very clearly, note, some localities are keeping closed. And that is county to county. And what they're going to start doing on the governor's COVID site is listing the counties that are reopening versus those who are not. And that they're desperately hoping that they can also, with everything else they have to do, make the cut to have that listed on the 27th, which is Monday. So the bottom line, though, is what you guys have done and what you guys did today. The medical guidelines I saw in his press conference, you guys knocked it out of the park. That is what our people need to do. And they need to understand that if you're not doing a 6-foot social distancing, you're going to have to do the PPE and sanitization medical distancing, right? Mm-hmm. That's just a reality. And they're sussing out a few details about what they are going to require.
Lara Lee, is it possible for you to send his staffer our PowerPoint so they know that we're already trained?
Yes,
We're already,
and yes. No, I've already communicated with the staffer that I think is the right person, but if she's not, believe me, she will let me know.
Okay.
She's not shy.
but specifically,
But
can you
right
just-
now they're using every staff member to do every darn thing to try to get through this process. So
right. It
just
might be
understand.
helpful.
I
It
think I got it to the right person, but I will continue.
well, did you get this PowerPoint?
Yep.
This one?
I did.
Great.
And I think it's great. And I think basically it looks like, and especially listening to the AAC again, I'm doing this because I've got a monitor here and I've got a monitor here and I've got a monitor over there. I've got like 7 monitors in my house right now. We are in total shine with best practices, best on what I heard from you guys, and then watching the governor's presser and watching his slides, which will come out in public, of course. We're ahead of the curve. So, because we always are, right? And he was very clear with me that he did not in any way mean to denigrate us by putting us in the personal services category. That was a communication goof, and he'll work on that. But he also said 5/1 is probably date soon. That's what he said, literally, specifically to me about the acupuncturists in Colorado, May 1. So I would look for that to be the date. So the good news is, that's a good date. The bad news is that's not a great date. But the other good news is it gives time for people to prepare their offices for what you guys have talked about today, because you're right on point with that package about how to get your office in the place it needs to be, because it's going to be different. It's just going to be different. We can't, all the cool things we have in the office, the diffusers and the salt lamps and all that stuff goes. Kids running around playing with toys goes. Like, all that stuff is online with what they were talking about. So we're ahead of the curve as usual. Go acupuncturists. But sorry, it's a pain in the fill in the blank.
Lara Lee, I'm sorry to interrupt. Oh, can you mute that?
Hey, Tuesday.
Hi, thanks so much for being back with us. There's a lot of confusion coming in the chat box. If Dora says May 1st, but the county says May 8th, what do people do?
May 8th.
May 8th.
Just wanted it on camera. It's not gonna
If you're in the county that says May 8th, the answer is May 8th, period, and stop. Localities have, particularly if you're in a home rule, and I could bore everybody to just tears with what the difference is between home rule and not home rule. But right now the localities have a lot of power around this. They always do in the state of Colorado. And May 8th. You do need to, and I keep saying, and Casey and many of others of us have spoken about this, there are a few places you need to check. Please don't call Dora, they don't have time, and they don't have the right answers necessary.
I think
call your malpractice insurance and double check that you're okay, and call your local to see what their date is.
Yeah.
Those are the 2 main calls you need to make right now, because the rest of it is, if you open too early by Dora's standards, which you can look up online, and they're actually doing a pretty good job of updating, even though their language is sometimes ugly. But the dates are correct. So look at the Dora website for dates, double check with your malpractice insurance, and double check with your locality, because if you open before your locality is ready, you will be fined, you will be potentially convicted of a misdemeanor,
really quick,
and then you will lose your license. And that's
So
it.
Lara, we want to be really, I need some clarification for myself, and I think Stephanie.
Sure, go.
Yeah, so Stephanie, so on those stay-at-home orders, it says people can leave their house for medical procedures. So
right,
that's what I've been trying to understand, is clearly Dora has said by May 1st, even as we need to not be open. But
Right.
all the county ones I'm reading, they're saying stay at home orders, not extending the PP order, the elective surgery order. So,
Right.
and so that's, I think, where there may be some confusion on all of this.
Oh, there's still confusion. This isn't completely sorted yet. But I really would say the two people you need to call to make sure you're clear are your malpractice insurance and your locality. Because as of May 1st, unless there's a change, we can be back in business as long as we practice really strict, everything you guys put in that beautiful presentation that you did today, really strict decontamination, you're fine. But I would make those 2 phone calls.
Somebody's been asking a question about Jefferson County. I just looked at Jefferson County and they say that the stay-at-home order, it goes through May 8th.
Yeah, no, there are a few counties. Boulder County is also, I think right now,
that's not the, as Stephanie's Ann says, that's not the question we have. So the question we have is, are we as medical providers under these stay-at-home orders?
Yes.
Why?
You are.
Why?
Because you always have been, and so you can go back to the stay-at-home orders, the original document that clarified that yes, you were subject to a stay-at-home order.
But in the stay-at-home order, it says medical clinics are exempt.
But that was clarified by Dora, I believe, about
yes,
what.
it was. So
but
we are not
under
considered. Yeah, we are still not considered medical clinics.
order?
I'm working on that.
Okay.
But
wasn't
if
that
you're
the
working in a hospital environment or one of those clinics, emergency clinics that have medical professionals, if you're working specifically with a doctor, okay, like not just a doctor of acupuncture or medicine, but like a medical doctor, and they can provide you PPEs, because that's also a stumbling block, right? Is how many PPEs are in the world and how they're being used. So if you're in a hospital environment, then you're probably back, Monday. But if you're not, we're looking at May 1st. And I would be very careful.
That's the question is then the stay-at-home orders. I mean, we'll get more clarity, I think, when Dora.
Oh, yeah. Well, we hope.
And we hope the counties will clarify.
I live in hope.
Yeah, I just know that if you really look at things, it's a confusing part, and since
it
we're in a
is.
happy hour.
I think
it's confusing.
I think the very confusing part is when some counties are letting people open up businesses earlier than May 1st, and yet because you have a license, you're supposed to only open up on May 1st. That's the confusing part.
Yeah.
And
no, it's still, just think about it. Think about this coronavirus, and I've said it before to some of you that I've spoken with this past few weeks, and I'll say it again. We are in an airplane going at full speed, fixing a problem. And there are certain things that are going to be scary and unclear. And I understand the economic desperation. I also understand that our practice, and I'm not an acupuncturist myself, but I feel a part of the community now very, beautifully, because you guys have accepted me so beautifully. But our practice says to the world that we are not just medical, we're also spiritual. And so losing that contact with the patient is very profound. And I completely understand that. So we want to get back to business as soon as possible for every reason that exists in the universe, right? And in some ways that doesn't even exist in other professions. So we have a very special place in the universe, and I want it to get us back to work. I want to start helping patients. I want us to be able to do what Tuesday's work has been, and she's been asked to do, and yet put off a little bit, because not put off like she didn't like it, but postponed, is going in to help these amazing first responders, because they need our help. So I'm working to get us back to work as quickly as possible. We also need to do what Casey told me the other day: at first, do no harm. And I'm going to put it just in a very callous way. I'm going to go politics now. I'm going to get off my spiritual high horse and go politics. I really want you guys to understand that I also don't want you to do harm to your own businesses. Okay? I don't want anyone to lose their license. I don't want another person to get outed. And by the way, I'm so working on that. To 9 News or some, ridiculous thing. I want people to not get fined, to not get misdemeanor charges, to not lose their malpractice insurance, but to continue to practice because the value of the practice is precious and is about to become more precious as people are coming out of this situation with all of these symptoms, including myself. I
think
I'm dying for some acupuncture. So I want to make sure that that's clear.
I'm looking at the state website for chiropractors, and they actually have been cleared to go back earlier than we have. So
Ish. They've been kind of cleared to go back. We have also been kind of cleared, but I asked the governor, and they are still being asked to wait until the Monday email comes out.
So they may that may change for them, because right now it says April 28th.
Right. A lot of email sites say April 28th.
No,
and
I'm looking at Dora.
No, I understand. And Dora is about to put out a new recommendation for everybody on April 27th. And so we're not really going to know until Monday what those recommendations look like. Now, I also want us to be very, very careful about competing with other professions right now. We've got other fish to fry, right? We can look at other professions, and I can use that as a lobbying tool. I'm already doing that. I have been doing that. But because I do want us back in business. However, we need to focus on getting everybody prepared, getting everybody rolled up. And I'm sorry that the other 5 days is going to hurt, but we're probably looking at May 1st, unless you're working in a hospital situation. And that's also mostly true of the chiropractors. I mean, what they've told chiropractors is if somebody throws out their back and can't walk, then you can see one person at a time. So it's a misnomer that they're totally back in business. In fact, it might be more expensive for them to be back in business than it would be for them not to be. And there are a lot of chiropractors I've talked to, because I'm very in touch with their lobbyists and their association, that are just not going back into business until they get the full Monty of, as long as you're doing the right things, you're clear. So they're in a similar position we are. Like, if you're in a hospital, they give you the PPE. You can find a way to do this in close contact with the PPE. You're on. Otherwise, you're off. And we're in that bucket right now. The buckets are a little fluid. I give it to you. And there might be a couple people that get to do things that we don't get to do yet, like a few days earlier, but it's only going to be a few days, because believe me, I am on this, and we're not going to be behind the curve. But we might not win every little tiny battle, and we've got to be very careful going into our practice act that we don't like have a slew of calls to Dora or stuff like that. Like, well, the chiropractors get to do this. It's 3 or 4 days, which hurts, but let's do the right thing, and make sure that we are putting ourselves forward as the profession that is the most careful, that has the least infection rate in our offices, et cetera, et cetera, et cetera. That's where we, as Casey said, our first responsibility is to our patients. And if May 1st looks like the date, May 8th looks like the date in certain counties, do it right. Do it careful. And if you do feel like there is a patient that is suicidal, in such pain they can't move, etc., one at a time, document, pardon my French, document the shit out of it. Document, document, document. So if anybody comes to you and says, you did this, you can say, we were declared clinical medical. We did all the right things. Here are my documents. But I would still call your malpractice insurance before I did it.
I just want to add Valerie's, all of the things with your checklists,
Mhm.
those are part of those documentation, right?
Yeah,
Mhm.
that's part of the documentation. I have a question for the group because this is something I didn't put into the thinking, but especially for where you're opening early. I don't know what this will look like a week from now for those practitioners that can't open till May 8th, when maybe we'll have some more answers. But what do you do about scheduling appointments for people who are really at risk?
I would recommend doing as much telemedicine as you can between now and then. We have been cleared both on email and verbally from Dora to do telemedicine and Chinese herbs for those who do Chinese herbs. And if you feel somebody is seriously at risk, then you have to make the personal and business decision about whether to refer them to a hospital, which right now, again, is fraught, but, or taking that patient alone and documenting the out of it.
Well, and I think this is why
So that you're covered, but that's pretty much all you can do. But you've also got to have the proper gear. If you don't have the proper gear and you can't give your patient reasonable gear, you've got to refer them to a hospital situation.
But why we like the Dora statement of critical care. I mean, there is those statements of critical care, suicide prevent, so
yeah, exactly.
Why there was so much confusion by what it created. It actually was a really intelligent loop, because we don't want to abandon our patients either. And so this
that's why I'm saying, if you have to see someone because you have to see someone, bring them in alone, sanitize everything, do all the right things that you guys talked about this morning that you put together so beautifully. Because you guys totally nailed everything the governor, I was listening to the governor's office thinking, oh my God, my team is so good. Look at everything they did. Everything was just so aligned. So do all of it. Do it one at a time for now, if you have to, and document the heck out of it. But I would also definitely not start until Monday if you can, if possible, have it. And if you can use telemedicine to speak to your patients and talk to them about the fact that they'll be coming home soon, at least soonish. I mean, I know we're not therapists, but
Lara Lee,
that's what I can do.
we have a great question from the chat. Do you know or have any inclination or any information related to whether we will be able to continue telemedicine after our ability to go back to work has been restored? I know it's something that we'll probably work to put into the Practice Act as we go through the sunset review, but in that interim period, do you have any information about that?
Well, currently we're on the telemedicine, we're in the telemedicine pool, and we're being asked to do more telemedicine than in-person medicine. So the answer for now is yes. And I am looking for an additional clarification on that. But again, I have email and verbal clarification from Dora that go forth and telemedicine. Just, don't, you've got to disclaim that you're not a therapist, you're not a psychological therapist, you're not a psychologist. But if you want to talk to someone about where their pain is, obviously you can't do needling over the phone. But, if you want to do pressure points and you want to diagnose herbs and then find out a way to distribute the herbs in terms of either delivery or curbside pickup, basically, that is definitely a go. But that's all we've got right now, because again, you can't needle over the phone. That's all I got. I mean, if you could needle me over the phone right now, my lower back is killing me.
Thank you so much. It looks like we're winding down. So I'm going to say thank you so much to all of our panelists, to Valerie and to Steve. Thank you for your time. Thank you for your hard work and your information. It's been absolutely stellar. Thank you to all the participants who were able to attend. I have been blown away at how many people wanted to be part of this, and super excited. And I hope that you will continue to be as involved as we move forward going into our sunset review and our practice act. So thank you all very much. Thank you to the board members who helped to put this together, particularly Casey Wardle, Mark Van Otterloo, Liz Love Fury, forgive me if I'm in Tuesday Wasserman, forgive me if I'm leaving anyone else out. It's been a long day.
Laura Lee.
Oh,
Laura
of
Lee
course.
has spent
I hadn't gotten to Lara Lee yet.
thousands of hours. Since COVID, literally thousands of hours. So thank you very much, Laura Lee.
Well, I am glad you are a demanding client because you absolutely deserve every moment. And I feel very proud and honored to have served you. And hopefully I'll get a chance to continue serving you as we go through the next, you know, this crazy time. It's going to be a lot coming down at one time. So
thank you all.
Thank you.
Bye, guys.